Hi everyone, my name's Professor Peter Nash from the School of Medicine, Griffith University in beautiful downtown Brisbane in Queensland in Australia. And today we're talking about some difficult issues in the management of rheumatoid arthritis. One of my pet areas to think about is the controversy between the ACR and the EULAR recent updated recommendations for management when they're talking about how to use low-dose corticosteroid. The ACR chose not to recommend it, and the EULAR recommendations were to continue to recommend low-dose oral prednisone, although, to be fair, they don't specify whether it should be oral, but it can be intramuscular, which is what we're trying to get to. Reason I bring it up is another presentation at EULAR in Milan by Crowson and his colleagues, and they looked at the RA population in two cohorts, one from 1999 to 2008 and another from 2009 to 2020. And they looked to see how we rheumatologists have been using steroids in our RA populations. And guess what? We're still using them, and we're using them more than we used to use them, even though we have a tremendous array of very effective therapies that are steroid sparers, so that 71% of patients are started on steroids. They're usually started orally. These people have more comorbidities, are more likely to be on a biologic at the end of 12 months. But even though the guidelines in EULAR say off by 3 months, I've always found it very difficult to get people off the last few milligrams of prednisone. And I've also found that occasionally, more than I'd like, once the person has the bottle of prednisone in their hand, they take a fistful when they're sore, then stop when they're feeling well, they're good for a week, then they flare, and then they're on the roller coaster. And it's very hard to control their disease while they continue to do that. The point that this particular poster made was that the more likely to start steroid if you're older, you're less likely to come off if you're older. Smokers are also much less likely to discontinue steroids. But the key point was 30% of patients are still on glucocorticoids at 2 years, exactly the same as the catch cohort from Canada. That was a paper from many years ago. And we're now seeing lots of publications. Martin Boers has recently published the Glorious study, and there's another recent publication, the Annals of Internal Medicine, this month, talking about, firstly, the Annals said that low-dose steroids puts on 1.1 kilos over a year or two. And it also talked about minor increases in blood pressure, which may well have relevance over time. And Martin Boers is saying how safe it is to use steroids in that population, even though there was more osteoporotic fractures, there was more people hospitalized with infections, et cetera, et cetera. So the bottom line is I'm very keen to use as bridging therapy corticosteroids, but intra-articular or injected rather than commence low-dose oral. What do you think? The evidence is out there on the efficacy of intramuscular and intra-articular steroid injection, and the evidence is out there of how difficult it is to get some patients off their low-dose steroid and the long-term effects of steroid use, driving weight gain, blood pressure, infection in particular, fatty liver, metabolic syndrome, premature atherosclerosis, etc. Thanks for your attention.